Welcome to Checking In, a Scottish Rite for Children podcast, where we'll share up-to-date expertise on children's muscles, joints, and bones. Scottish Rite for Children is one of the nation's leading pediatric orthopedic centers. Since 1921, we have been committed to caring for the whole child, mind, body, and spirit. Today, our world-renowned medical staff treats a wide range of pediatric orthopedic conditions, including sports injuries and fractures. Our specialists also excel in the treatment of related arthritic and neurological conditions, as well as learning disorders like dyslexia. Through outstanding care and compassion, Scottish Rite has become a place of hope. We are dedicated to beating the odds in the face of adversity because it's our mission to give children back their childhood. And now, your host, Jennifer Bowden.
Hello, everybody. We are checking in with Dr. William Morris today. We're excited to have him back on our podcast to talk about developmental dysplasia of the hip. Dr. Morris, can you kind of start us off with a background, kind of defining what is developmental dysplasia of the hip?
Sure. Well, developmental dysplasia of the hip is a condition where the ball and the socket of the hip joint don't develop normally. So normally the socket, which is also called the acetabulum, really covers the ball, which is called the femoral head, well and deeply. But in developmental dysplasia of the hip, or DDH, which is a term we'll use a lot for the rest of the interview, I'm sure, the socket ends up being a little bit shallow so that it doesn't cover the ball as well as it should. And dysplasia is a bit of a bad term for this because what dysplasia would suggest that there was something wrong with the socket itself, like the cells that make up the socket. But really, this is more like a malformation. So instead of being a perfect, round, deep socket, the socket just ends up a little more shallow. And so this can present in kids or in adolescents as a slightly shallow socket all the way up to a hip that's frankly dislocated.
Okay. Interesting. Is there a certain group of patients, a different type of patient population, that are diagnosed with DDH?
Sure. Well, in infants, I think we're going to talk a little bit today about both infants and adolescents. But in infants, what we really think of are the 4 Fs for being risk factors. That's female, firstborn, family history, and then being feet first or breech presentation. And female biologic sex is present in about 80% of cases. So that's a pretty common risk factor, as is being firstborn, which is present in about 60% of cases. As far as family history, we know that confers about a 12-fold increased risk. And so if, maybe mom or dad or someone in the family either was treated or has a history of dysplasia themselves, or if there's maybe a history of early hip replacement in the family at a young age, then that's considered a potential risk factor for the baby having dysplasia. And then finally, being feet first or breech, we know is a pretty significant risk factor. When you look at a lot of the studies, seeing how many what percent of breech babies have a shallow hip socket, it looks like it's somewhere around 15 to 25% or so in more recent studies. And we actually just submitted our own study looking at our population here at Scottish Rite, and it looks like it's about a quarter as well. So all significant risk factors. And those are things that you kind of come in with that are non-modifiable. But aside from those, we also know that environmental factors seem to play a role in how the hip develops. And so when you look at different cultural groups from different geographic areas, you see that there's some groups where there's this huge rate of dysplasia, and in others it's less. And the punchline is not that there's big genetic factors, although we know that plays somewhat of a role. For example, that female biologic sex carries an increased risk. But really, it suggests that there's a lot of importance in how we take care of our baby's hips after they're born. And so we'll talk eventually about the importance of swaddling the hips and how to do it safely so that we can encourage those hips to continue to develop well.
Okay. You kind of touched on it a little bit, but can you kind of elaborate on what actually causes DDH?
Well, as I mentioned before, developmental dysplasia of the hip is a condition where a hip which developed normally as an embryo becomes shallow during development in the womb. And we know that there are some genetic factors which can play a role. Like I said, there's some genes that can contribute. We know that female biologic sex is a risk factor. But ultimately, other risk factors are things that contribute to the ball not being positioned nicely against the socket in the womb. And so that's why, for example, breech positioning is considered a risk, because instead of the ball or the femoral head being positioned nicely against the socket, it's in an abnormal position as the baby is developing in the womb, and this can lead to a malformed or shallow hip socket. Likewise, after the baby is born, swaddling the hips with the legs in forced extension, and we'll talk about that again, I imagine later, can prevent the hips from continuing to develop well. Because the ball and the socket are almost like kind of wet moldable pieces of clay when you're young, where having the ball against the socket makes the socket deeper and more round, and then having the socket against the ball makes the ball more round. And so all of those factors can contribute to the hip developing normally or abnormally.
Okay. That's a helpful explanation about the clay. That's a good example. For those that are diagnosed during infancy, what should new parents know? What are some of the important things that you tell new parents?
Well, I'd say that the single most important thing that parents should know is that developmental dysplasia of the hip is treated very successfully, and that the vast majority of the time we can do so without surgery. In fact, even in the most severe cases, which would be a frankly dislocated hip, we're able to treat and normalize those hips over 80% of the time just with a harness or a brace that the baby wears without having to go to the operating room. And even in those rare circumstances and severe cases where we do have to go to the operating room, our goal is still the same, to put the ball back into the socket deeply so that the hip can develop well. And so one way or another, we're going to take great care of your child, and hip is going to get positioned well within the socket. It's just a matter of trying to figure out what's the best and safest way to do it. And so for this really common condition, which happens in about 1% to 2% of births, we can treat it very successfully. And so we don't want parents getting too worried once they hear about the diagnosis. It's just important that we get a chance to see them so that we can initiate treatment.
Okay. What types of questions should parents be asking their pediatricians if DDH is, suggested or detected during, one of their first visits?
Well, I think the pediatricians in general do a fantastic job, first in the newborn nursery and then at those follow-up visits after discharge from the hospital, so kind of the 2-week visit, the 2-month visit, and so on, in terms of assessing the baby's hips and asking about risk factors. So if, mom or dad already knows that there's, for example, a family history, or they know about the breech presentation, they can talk to the pediatrician and make sure that they're getting a referral placed in a timely fashion so that their child can be evaluated. But otherwise, I don't know if there are specific questions to ask once the diagnosis is suspected. I think, after there's a suspicion, the most important thing is following through on that referral that the pediatrician is placing so that we can evaluate DDH and either confirm its diagnosis, and if so, start treatment. I think one of the important points is that we're very successful treating DDH non-operatively, but it's important to get started early. And so we want to be able to see your child within the first few months of life.
I agree that referral is very important after that conversation's taken place. But explain, why is it important for them to see a pediatric orthopedic specialist? I mean, why wouldn't they just continue to see their pediatrician, or continue to see, just a general orthopedist?
Well, although DDH is pretty common, I mentioned before it's 1% or sometimes considered up to 2% of kids that have DDH, it's still a complex condition, and there's many nuances, both in terms of its management as well as its ongoing surveillance. For example, there are some circumstances where we may just observe for a brief period of time to see if the mild dysplasia resolves on its own. In general, this is a condition where once it's identified, it's treated at a young age by a pediatric orthopedist. And so going in and getting to see an expert in the field, I think, is essential to making sure that your child has the best outcome.
We'll be right back after this.
To receive the latest news from Scottish Rite for Children, patient stories, videos, blogs, and more, follow us on social media. Through Facebook, Twitter, and Instagram, we share inspirational stories and educational resources for you and your family.
We're back to Checking In with Scottish Rite and your host, Jennifer Bowden.
Tell me what's the process when a baby with potential DDH is brought to Scottish Rite? Can you kind of walk us through that, what you're looking for, kind of what happens?
Yeah, absolutely. We get the privilege to see a lot of very cute babies who are referred over for concern for hip dysplasia. And so, the first part of our visit is going to be a chance to talk, because we're going to ask about some of those risk factors that you and I spoke about earlier. So, you remember the 4 F's about being female, firstborn, feet first or breech, and then whether there's a family history. And that conversation initially is important not only to help inform, what sorts of studies or information we may need to obtain at that visit, but also how much or how long we may need to continue to follow, that child as they continue to grow. Afterwards, we have a chance to do a physical exam, and we can see some signs of dysplasia on exam. So if you ask what we look for, we might see things like asymmetric thigh folds, and this is something that when you're changing your baby's diaper, you might notice, where it looks like there's kind of a few cute rolls on one thigh versus fewer on the other. Or asymmetric hip abduction. So again, while you're changing the diaper, one leg seems to fall out to the side further than the other. Those can both be signs of dysplasia. And so we look for things like that, or as we move the hip and take it through certain maneuvers, we might note that there's some clicks or clunks of the hip, which is another common reason for referral.
Okay. What are there any tests that we do? What types of tests are done when they're here to see us?
Well, after we've had a chance to examine the child, we then have a chance to do studies that are either based on ultrasound or plain radiographs, and that kind of depends on the patient's age. So, for most of the kids who are referred over to see us, that's done at a younger age, and the mainstay of our imaging up to about 6 months of age is ultrasound, because a lot of the structures around the hip are still primarily made of cartilage instead of bone, and so we don't get as much information on X-ray as we do on ultrasound. And so we can look at the hip and we can objectively measure the shape of the socket, the position of the ball relative to the socket, and we can use that information to either confirm or rule out that diagnosis of dysplasia. In cases of screening, for example, let's say that a baby is referred over because of a history of breech presentation. Everything else has felt fantastic about the hips at all those pediatrician visits, but because of that breech history, they're referred over. And in those cases, we usually get the ultrasound of the hips around 6 to 8 weeks of age, so that we can assess the shape of the hips and reduce the risk of what we call false positive tests. And the idea of waiting a little bit longer if there's no concern for instability of the hip and it's just being referred, baby's just being referred over for, a concern about a risk factor like breech presentation. The reason why we wait a little bit is that if we performed ultrasound on every single neonate on their day of birth, one study suggests that 15% of those babies would look like they had a dysplastic or unstable hip. Even though if we tested all babies at 6 weeks of age, we'd find there was only about 1%. So we know that at a younger age, some babies' hips may appear to be a little shallow or a little unstable, just due to their physiologic immaturity, meaning they still have mom's hormones coursing around in their blood, and they're a little younger. And then if we waited a little bit, we would see a normal ultrasound and we wouldn't need to treat. Because of that, we try and wait until that 6 to 8 week mark so that we decrease the amount of unnecessary tests and treatment. However, if on exam we see some of those clinical signs that would suggest there's some instability of the hip, we'll go ahead and get that imaging earlier because we want to identify and go ahead and treat early so that we can be as successful as possible in protecting that hip.
Gotcha. So we've seen them for the initial visit. We've done the exam, we've done X-rays or ultrasounds, and now kind of walk us through what happens if DDH is detected. What are the treatment options, and what do we do if they are diagnosed with DDH?
That's a great question, and I think one that probably a lot of parents are already worrying about if they're listening to this after being referred over. In some cases, we see that there's really mild dysplasia. So it's a slightly shallow hip. And, I told you that on the ultrasound, we can measure out different markers of the shape of the hip. And if we see a really mild case, particularly in younger patients, there's a chance that we'll just keep an eye on them. So maybe repeating an ultrasound a little bit later and observing them in the meantime to see whether there's resolution of that mild dysplasia on its own. In cases where there may be a little more pronounced dysplasia, or the patient's a little bit older, and so we don't accept even small amounts of dysplasia in older patients, then we generally initiate treatment with a Pavlik harness. And this is a special brace that generally holds the hip in a position of flexion and abduction, meaning the hip is flexed up and out to the side. And as you remember, when we talked about what are those risk factors for creating DDH, we talked about how the hip develops really well when the ball is positioned nicely against the socket. And the ball being against the socket makes the socket deeper and rounder, and then that makes the ball more round. And that's the purpose of the harness. It still allows the baby to move and kick its legs, but the hip is kind of held in this really healthy position that helps to encourage that socket to develop. And so even if we have a hip dislocation, kind of a more severe version of dysplasia, this is still our first treatment. And even in those severe cases, it still successfully treats the patient to bring the ball back into the socket and to fix that shallow socket, the vast majority, almost 85% of the time. Occasionally, in more refractory cases, the ball doesn't drop into the socket. And so we have a different sort of brace that we might try depending on the patient's age and their exam after the Pavlik harness. But if we can't get the ball into the socket, our next step is then to go to the operating room. And the idea is that after a number of months have passed with the ball sitting out of the socket, the muscles and soft tissues can kind of get tight and contracted, and it makes it a little harder for the ball to drop into the socket. And so in the operating room under anesthesia, the muscles can relax and you can have an easier time manipulating that hip back into the socket. So under anesthesia, we have a chance to see if we manipulate the hip, can we bring the ball back into the socket? Is it stable, meaning will it stay in that position? So we can obtain some images at that time to try and figure out, is the ball well positioned in the socket just by manipulating it? And is it stable there? And if so, then we can just go ahead and put on a cast. And instead of a harness, we use what's called a spica-caster, one that goes down from goes up from the legs all the way to the torso, and it helps maintain that hip in the reduced position, kind of like the Pavlik harness. It helps maintain that healthy position so that everything can remodel and become a round, deep socket again. Sometimes we can't manipulate the ball into the socket, or we do, but it doesn't want to stay there. And in those cases, we do what's called an open reduction. And that's where we actually make an incision in the skin so that we can open up the hip joint, remove all of the obstacles that are trying to prevent the ball from seating deeply in the socket. And then once the ball is seated deeply in the socket, then we can do the same steps where we put that cast on, maintain that position, and allow it to heal and remodel there so that it becomes a more normal socket again.
Got it. So that's kind of the hierarchy of treatment. But talk about swaddling, Dr. Morris. I know we get this question a lot. What do parents need to know about swaddling if their baby has DDH?
Well, I think I probably spend more time talking about swaddling with parents of kids who do not have DDH, who have totally normal hips, than I do with parents of kids with DDH, because it's such an important point and everyone needs to know about it. So when you're at home, if you're swaddling your child's hips or you're swaddling them into a blanket, like a receiving blanket, the best way to do it is to swaddle those arms in, okay, so you can tuck them in nicely, or if your baby likes to, get their arms up, you can just swaddle and secure the chest or torso snugly, but then leaving a good amount of room around the legs. So that way the baby has room to flex their hips and bring them out, kind of like the position that we like to put their baby's hips in, either in the cast or in that Pavlik harness. One device that's really negated this conversation for me a lot of times is that more and more people are using sleep sacks, and it's the same principle that you have something that snugly holds the chest or torso, but you have that big capacious area down by the legs so that the baby can flex their hips up. And so either way, whether you're using a receiving blanket or whether you're using something like a sleep sack, it's all great as long as the baby has room to flex those hips up. And again, I think this is a really important point because we know how much of an impact on early hip development swaddling can have. There's actually a really cool study out of Japan from the 80s where they looked back and they said, man, if we look at our rate of dislocated hips, so severe dysplasia, compared to the rest of the world, theirs was 30 times higher. And they said, God, why would that be the case? And we were starting to understand the importance of swaddling the hips and extension at the time. And there, culturally, there was something called a swaddling diaper, which was prominently used, and it kept those hips extended, so it didn't let them flex up. It was tight around the hips. And so they instituted a national campaign to try and change practices and instead use these safe swaddling techniques like I just described, where you may swaddle the arms in, but leave the legs with more room to flex up. And they were able to reduce their rate of dislocation down to where everyone else was, so almost a 30-fold decrease just by changing that practice. So it's really important, not only for parents of kids who have dysplasia, but for everyone just to know.
Yeah, thanks, Dr. Morse. That was an excellent explanation of the swaddling. I know we get that a lot. And I know the sleep sack, that has helped us a lot, kind of make it a lot easier for parents to understand and to visualize the correct and incorrect ways to swaddle. For a baby diagnosed with DDH, do they need to be seen regularly throughout their life? They need, continuous follow-up?
Well, I think that whether or not we continue to surveil hips depends on a number of factors, including risk factors such as, whether they were a breech or there's a family history, as well as the degree of dysplasia or residual dysplasia. Some babies we know, for example, have a high risk of having dysplasia in the future, or for it to correct completely, such as those who we had to take to the operating room. For example, we know that if we manipulate the hips into place because of a pretty significant dysplasia, then about 50% of those kids are going to go on and likely need some sort of procedure in the future. So it's really important that we keep an eye on them as they grow. Conversely, if there's a baby who maybe was treated by observation and it resolved on its own in a few weeks, then maybe somebody who's monitored for less time or not followed as long. And so, there's really a number of factors, and that's something certainly that your surgeon will be able to talk you through and kind of justify why we're doing one thing versus another. Because this is one of the many reasons why it's important to get in with a pediatric orthopedist, because one size does not fit all, and there's a lot of different permutations and different ways that we manage or monitor that can affect the way we take care of your child.
Okay. Are the kiddos that are diagnosed with DDH, are they more prone to hip complications into adulthood, say arthritis, other hip issues, as they grow?
Well, I think that if the patient has pretty mild, dysplasia and it's treated and they don't have dysplasia anymore, then you've addressed the mechanical problem. And I imagine we'll talk about this when we look at adolescent dysplasia. But as you get older, if the socket remains shallow, we know that is a problem that can cause arthritis. So mechanically, if you're standing and you're putting the weight on the socket, and one person has a big, broad, deep socket to distribute that weight, and then another person has a shallow socket where you're just putting weight on a small area because you don't have as much coverage, then the person with less coverage, where all of that force from weight bearing, from doing activities, is concentrated on less cartilage, that person's at higher risk of developing arthritis. And there's some great studies from decades ago that followed kids and looked at how shallow or deep their socket was, and then whether or not they developed arthritis in the future as adults. And what we saw is that, kind of below a certain threshold, a patient is likely to have, much more likely to have early arthritis. And that's the whole reason why we're treating patients, is we're trying to prevent arthritis at a young age. So all of the treatments as an infant are done so that way that same child as an adult keeps their native hip for 60, 70, 80 years rather than having a hip replacement when they're younger.
You're listening to Checking In, a Scottish Rite for Children podcast.
Do you have a story to tell? We want to hear it. Sharing your experience with us can provide inspiration to other patients and shine light on our mission of giving children back their childhood. Whether you are a current or former patient or family member, we invite you to share your journey with us. To submit your information, visit scottishriteforchildren.org/share your story.
Welcome back to Checking In, a Scottish Rite for Children podcast.
So let's kind of flip over. So we've talked about DDH during infancy. Let's flip over to adolescence. So when it's DDH is diagnosed during adolescence, what are the common symptoms for DDH when kids are adolescents? So, during the ages of adolescence.
Yeah, well, I think unlike infants where there may be a hip click or the history of the family that's kind of bringing the patients in. Frequently in adolescence, patients are coming in because they're having pain. And we don't think of dysplasia as being painful in younger kids, like in infants or, young school-age children. But by about middle school, high school, or college age, adolescents can start having pain related to the dysplasia. And that's usually kind of an anterior groin pain, or very frequently, it's pain on the outside of the hip, usually after activities or at the end of the day. Frequently these patients are very athletic and they might still push through their sport or competition, but with some pain either during or afterwards. And occasionally, if there's an associated cartilage injury, there may be something like locking, catching, or popping in their hip.
Okay. In the adolescent, how is DDH diagnosed?
Well, in comparison to the infants, where we used primarily ultrasound, in adolescents or young adults, we use X-rays to look at the position of the socket, its development, and see how shallow or well covered the hip is. So we can combine that information with our exam, because we can do things like assess where their pain is, try and provoke their symptoms to see, is somebody having symptomatic dysplasia, meaning does it seem like they have a slightly shallow socket, but their symptoms are not coming from that, or is that the source of their pain, and we can provoke it in clinic. So we use a combination of physical exam as well as radiographic findings to help try and evaluate that hip coverage.
Sheik, what makes DDH different than common hip pain? Kind of talk about what the differences are and kind of what sets it apart.
Sure. Well, there's certainly a lot of different reasons that patients can have pain around their hip. There's certainly many different muscles and tendons that are crossing the hip joint, and particularly in younger athletes, a lot that can become inflamed or irritated. And in comparison with kind of some other short-lived aches and pains, adolescent dysplasia is usually a pain that starts in teenage years, and as I said, kind of is more of an anterior or a lateral pain, and it's something that's going to be activity related and probably going to persist rather than something that gets better after a week versus a strain, a muscle strain or pain that might get better after a little bit of rest. As I mentioned before, we don't usually see pain from dysplasia and more mild dysplasia in younger patients. They tend to run around and keep up with their peers. But in older patients, again, this is something that we tend to see as patients are participating in sports, and it's kind of a fatigue or aching type pain, or something they notice at the end of their activities. Again, in comparison to something like a muscle strain, this is a mechanical problem, because all of that force from weight bearing, from running, sprinting, cutting, is being distributed over a smaller area because of that shallow socket. It eventually can become irritated or painful. And without treatment, those symptoms usually persist.
I see. So, is it sports that can cause DDH? Is it too much activity? Can you kind of talk a little bit about what causes DDH in adolescents?
Well, the short answer is we don't know. It's interesting that in infants, developmental dysplasia of the hip happens, like as I said before, in about 1 in 100 kids. But dysplasia in adults is closer to 3 in 100. So where do those, where does that number go from 1% up to 3 or even 5%? So we don't have a great answer for how that happens. And, that's a great question that hopefully will get answered in the future. I think one point probably important for parents is that there's not one specific activity that your child does or does not do that will cause dysplasia. So we don't have a great answer for it, but it's certainly not something where lack or too much stretching is causing it, for example, or participating in one versus another sport. There's certainly sports where we tend to see more dysplasia, like ballet dancers, for example. But then there's the question of whether it's the sport that selects the patient with greater hip range of motion due to dysplasia, or whether the condition actually is associated with it. And so we don't really have the answer to that yet either.
I see. So what, if an adolescent is diagnosed with DDH, what are the treatment options for an adolescent patient?
Well, I think that a lot of kids can feel better first with physical therapy. Remember, this is a mechanical problem where the hip is working harder because it's working with less surface area, so that cartilage is more likely to get irritated. And the muscles on the outside of the hip are more likely to get fatigued because they're working harder to hold that hip stable because it's not as well seated deeply in the socket. And so sometimes physical therapy to help try and strengthen the muscles that stabilize the ball in the socket can reduce the pain and fatigue associated with activity. And so for some kids, that's all they need, and they're back to participating in sports. That doesn't solve the mechanical problem of the socket being too shallow, but frequently that can either stave off or resolve those symptoms for a number of years. And if the dysplasia is mild, then maybe there's nothing else that needs to be done. In patients where physical therapy, anti-inflammatories do not affect enough relief, surgery can be performed to try to reorient the socket around the ball and cover it better. And this is performed to try to reduce pain from the dysplasia, and also kind of from a 50,000-foot view to try to protect the long-term health of the hip. With surgery, we're primarily addressing the mechanical problem of the socket being too shallow, and that surface area that the ball has to distribute forces across the socket is too narrow. And so by reorienting the socket, we can make a broader surface area, better distribute those forces, and hopefully reduce the risk of early osteoarthritis, as well as improve a patient's pain and function.
So I know we get, a lot of referrals for DDH and hip pain and hip concerns, but, for the parents and kiddos out there, that haven't gotten a referral yet or haven't had their concerns addressed, what happens? What happens if DDH continues without being detected or examined or diagnosed?
Well, I think, you can look at that in the short term and the long term. And, in the short term, if somebody's considering, whether or not they need to come in for evaluation, I think that if a patient does have developmental dysplasia of the hip and that socket is shallow and the patient has pain, we need to try and do something. And that doesn't necessarily mean surgery, because I think we are very successful with physical therapy and with anti-inflammatories, because I think it's going to be a little more challenging for the patient to get back to their sports if they don't come in and get checked out and get plugged in with the right exercises with great therapists. If you kind of take a 50,000-foot view long term as far as the health of the hip, I think that it's really important to come in and get evaluated, because some hips don't respond to physical therapy and do need surgery. And if the mechanical problem of the hip is not addressed, meaning that if the socket remains shallow and doesn't really cover the ball, so that the patient is putting all of the weight on that narrow area of the socket, that they're more likely to get arthritis. And we don't want that, obviously, for our patients at a young age. We want them to keep their native hip joint for another 50, 60, 70 years after we've gotten to know them. And so it's really important to come in, get evaluated, and figure out what's the best way that we can address their symptoms. There's a lot of literature out that shows that not only does dysplasia cause arthritis, but also that it's unfortunately a common cause for young hip replacement. And so there was a recent study out of St. Louis that looked at all the patients who were having a hip replacement before 50 years of age, and about half of them, the reason for that hip replacement was dysplasia. And so I think identifying these patients at a young age and getting them either treated effectively with therapy or with this reorientation osteotomy called a periacetabular osteotomy is really important so that we can protect the lifelong health of that hip.
Gotcha. So would you say, Dr. Morris, that, if parents are concerned or, their kiddos are complaining, the most important thing is to get it checked out. Ask your pediatrician, ask your family doctor, whoever you need to ask. But definitely, would you say it's important to bring that to your doctor's attention?
Yeah, absolutely. There's certainly a lot of kind of short-lived aches and pains that come and go, but if your child is having persistent pain in their hip, it may be limiting their activities, or they might be gutting it out and just pushing through. That it's important to get checked out, just so that you can have the information, know whether dysplasia is the source of the pain, and if so, know that there's a number of ways that we can help.
Great. Just before we wrap up, Dr. Morris, I know we've talked to you about research before in the past, but kind of touch just briefly on, what type of research are we doing, regarding developmental dysplasia of the hip?
We're doing a number of really neat studies right now at our Hip Center of Excellence. We do research both in infant DDH as well as in adolescents. And I think right now in infants, I think some of the neat things that we're looking at is some of our outcomes. So what happens after you either manipulate the hip in closed or whether you have to make an incision to bring that ball back into the socket. Because we're starting to learn more about who's better suited for one versus the other and what factors may predict who's going to need some other procedure done later on. Who do we need to keep a close eye on? And potentially, how can we change our treatment of patients at a young age? So when we're seeing them as infants, that might improve how they do down the line. So that's started off as one study that led to another question that led to another question. We've kind of gone down the rabbit hole and are trying to change the way that we look at kind of the treatment in developmental dysplasia of the hip. And so I'm very excited about those studies and where they're going to take us. And then for adolescents, we're doing one neat project that we're doing right now is actually working with our gait analysis department. So we've got a fantastic movement science laboratory so that we can help understand the best way that we can correct adolescent or young adult hip dysplasia and see how what we do impacts the way patients get back to walking and running. Because, as I mentioned a few times now, dysplasia is a mechanical problem. So we're trying to address and improve those mechanics. And, the precise way that that's done, how much correction we're dialing in may have an impact on the way that the patient walks afterwards, and how well we've corrected that mechanical problem can be seen in a movement science laboratory. And so we're really excited to see what that shows and whether that gives us any sort of guidelines that we can then share with other surgeons to, how to gauge the correction that we're obtaining and how it's going to improve our care of children and young adults.
It sounds like, we already know so much about DDH, but talk to us about why it's important to continue our research in DDH.
Well, even though these are all common problems, there's so many questions that we can still answer to try to improve how we take care of our patients and protect the lifelong health of their hips. I think it's obviously a really important area because it affects so many people. We talked about that developmental dysplasia of the hip affects 1 in 100 infants and maybe 3 to 5% of the young adult population. This is there's great opportunities here to affect changing a number of people's lives in a huge swath of the population. So, the more that we can learn and the more we can improve the way that we take care of these conditions, the better we can affect, these kids and young adults' lives. So it's really exciting to have that opportunity here because there's, tremendous resources and, it's a great history of taking care of these conditions for decades that allows us to look back, and gauge what we've done and what it's taught us. But it's certainly important to keep seeing how we can help push the field forward to learn more and try and improve how we take care of it.
Gotcha. Well, Dr. Morris, this has been super helpful and super informational. I think that we got a lot of great knowledge about developmental dysplasia of the hip and what it is and what to do with it. We really appreciate your time and your expertise, regarding DDH. And thank you for being with us again on Checking In.
Thanks so much. It was a pleasure. I look forward to finding another chance to come on and chat.
Alrighty. Thank you very much, Dr. Morris.
more information about any of the topics discussed on today's podcast, check out our website at scottishriteforchildren.org. And be sure to subscribe to Checking In with Scottish Rite. This podcast is a production of Scottish Rite for Children. The host for this episode is Jennifer Bowden. Our producer is Maggie Dingwell. Our editor is Amy Krajewski. Our assistant editor and recording engineer is Stuart Allman. Our theme music was composed by Scott Holmes, and his music can be found at scottholmesmusic.com. Thanks for listening, and we look forward to seeing you at our next episode.